Welcome back to Dr. Talks. Today we'll be dealing with cystic fibrosis. So what is this cystic fibrosis? What is it? Cystic fibrosis is also called as mucoviscidosis. What does it mean? That means that every secretion in the human body will become thick. Normally the secretions in human body, which is usually more fluidic, this fluidic secretion will become very thicker. This thick mucus throughout the body is what is called as mucoviscidosis, also called as cystic fibrosis. How does this normal secretion become thicker? That is because of a mutation. Autosomal recessive mutation. If CFTR gene, this means cystic fibrosis transmembrane regulator gene on chromosome 7. This codes for the chloride channel. So what happens? This is the epithelial cell. You got both the chloride channel and the ENaC channel. So this chloride channel, what is the normal function of chloride channel is that the chloride will go out. This chloride will inhibit the functioning of ENaC channel. What is the function of ENaC channel? ENaC channel will reabsorb sodium and water. This will secrete chloride. This is the lumen. This is the cell. So what happens in cystic fibrosis is that what is the normal function of chloride? When the chloride is secreted from within the cell to the outside into the lumen, this will inhibit the reabsorption of sodium and water by the ENaC channel. Thereby, the mucosal secretions are watery. What happens in cystic fibrosis? Because of the gene autosomal recessive CFTR gene mutation, this chloride channel will not function. When there is failure of functioning of the chloride channel, there will be overfunctioning of the ENaC channel. ENaC channel overfunctioning will reabsorb water and sodium. This will result in a thick mucus. So this is the basic problem in cystic fibrosis. So why it is an important disease? This is because cystic fibrosis is the most common single gene defect. It is the most common cause of exogenous pancreatic insufficiency in children. It can also cause chronic respiratory infections in children. It can cause even adults will have recurrent infections in adult population also. It is the most common deadly genetic defect because of single gene mutations. So how do they present? How does a cystic fibrosis patient present? The earliest findings in a cystic fibrosis will be cough. Cough will be the earliest finding, and when you do an PFT, you find the evidence of small airway disease. It will begin earlier in this area, and also chest X-ray will also show a small airway disease in the form of an increase in the residual volume by total lung capacity ratio. This will be the form of hyperinflation. Hyperinflation predominantly affecting the right upper lobe, which is the most commonly affected and more severely affected. This is the earlier finding. The other findings of respiratory findings include broncholectasis in children. In adults, they can develop with bronchiectasis. Recurrent cough, recurrent infections, recurrent bronchial damage will cause bronchiectasis. Along with that, they can also have upper respiratory findings in URI, the frequent upper respiratory infections, chronic sinusitis. The patient can also have nasal polyps. So it initially begins as a small airway. This broncholectasis will be the initial manifestation. In later stages, can involve the bronchiectasis. And will have chronic upper respiratory infection, sinusitis, nasal polyp, and evidence will also be supporting the chronic lung infections. So this is the first one, is the lung infections. Secondly, they can also involve the pancreas. In the pancreas, they can manifest as exogenous pancreatic insufficiency. Because of thick pancreatic secretions, there is exogenous pancreatic insufficiency. That is decreased absorption of vitamin A, D, E, K. Along with that, there will be fat and protein malabsorption. The patient will have foul smelling, bulky stool passage, foul smelling, frequent bulky stools will be passed, and the fecal elastase level will also be increased, which can be used as a marker in the diagnosis. So this is the pancreatic insufficiency. Later stage, endocrine pancreatic insufficiency can also occur if the patient will go for complete pancreas destruction. So this is the earlier manifestations. The other findings, it includes the gastrointestinal system, especially in children. Children, they will cause meconium ileus, meconium peritonitis, and it also cause meconial plug syndrome. Because of the thick feces, because again the same because of more of water and sodium reabsorption, the stools will become harder, and the baby will present with a delayed posture of meconium more than 48 hours. And if this meconium can sometimes obstruct the ileum, resulting in the abdominal distension, vomiting, frequent failure to pass meconium, such a presentation. Sometimes their bowel will go for perforation, and this perforation can result in the calcification of the peritoneum and scrotum, which can occur in utero. That is called as meconium peritonitis. Meconium ileus is the ileal obstruction of meconium, and there is failure or delayed passage of meconium that can also be present. So the GI manifestations. Then the genitourinary manifestations. Genitourinary manifestations in the form of infertility, male infertility, because of azoospermia. Why do they develop azoospermia? This is because of absorption of the vas deferens because of the thick fluid. This is male infertility, and female infertility. Again, female infertility because of cervicitis, because of thick cervical mucus. There will be difficulty in passage. The sperms cannot pass into the pass those thick secretions. So this is the findings. So summing up, the patient have chronic respiratory infection or pancreatic insufficiency. The patient can have increased sweat chloride levels. The patient can have meconium plug syndrome or all GI manifestations. The patient can have genitourinary manifestations. How do you diagnose? Diagnosis is because you have to have a history of the clinical picture. The above discussed clinical picture should be present. One, then they should have a positive sibling, a brother or a identical twin or a sister, will be positive siblings with history of cystic fibrosis. Then newborn screening should be positive. What is this newborn screening? Newborn screening is done by immune reactive trypsinogen. This immune reactive trypsinogen by newborn screening test will be positive. That will help in the early diagnosis of cystic fibrosis. Also, there will be certain genetic mutations. You should have identified two different genetic mutations, either a delta F 508 mutation or an R117H mutations. There are a lot of mutations. The cystic fibrosis is basically be classified into 5 types: CFTR 1, 2, 3, 4, 5. CFTR 1, 2, 3, they are more severe with more sweat chloride levels and more pancreatic insufficiency. The 4 and 5 will have less severe and less severe pancreatic insufficiencies. Then they will have epithelial sodium sweat chloride levels. A sweat chloride level of more than 70 milliequals in adult or more than 60 milliequals in children is diagnostic of cystic fibrosis. Then abnormal transnasal epithelial potential difference. This abnormal transnasal epithelial potential means there will be increase in the transnasal epithelial potential 1. There will be a decreased response to beta agonist, and application of amilorate will abolish this increased transnasal epithelial potential. So this is the sum total of the diagnostics. And also we have got microbiologically an evidence of a Burkholderia capacia infection or a Haemophilus influenza or a MRSA or Pseudomonas or Aspergillus fumigatus or some gram-negative organisms like Proteus, Klebsiella. This especially the Burkholder capacious pathognomic of cystic fibrosis patient and Pseudomonas aeruginosa. They will be mucoid strains which will be highly infective and they will be resistant to antibiotic. The colonization of these organisms in a newborn's airway, think of cystic fibrosis. So coming to the management of cystic fibrosis, first you have to clear the secretions. How do you clear the secretions? By inhaled bronchodilators, inhaled hypertonic saline, and the mucolytic agents like Dornase. It is a DNA breaking enzyme which will make the secretions less viscid. Then go for antibiotics. Antibiotics for MRSA, you have to go for vancomycin. For Pseudomonas, you have to go for piperacillin tazobactam or any anti-pseudomonal antibiotics. Then inhaled gentamicin or tobramycin can be given. Inhaled tobramycin can be used in treatment of cystic fibrosis exacerbation. Then you have to go for a special drug called as ivacaftor. This ivacaftor, it activates the CFTR channel and it will improve the chloride content. Hence, it is a reactivator, chloride channel reactivator. If the patient goes for any respiratory failure or patient goes for carpulmonale, then you can try lung transplantation as the last resort. So summing up, any newborn presenting with delayed passage of meconium, or a patient with abdominal distension or a meconial peritonitis, or any young patient with recurrent episode of bronchiectasis in an younger adulthood, the patient having recurrent lung infections with pancreatic evidence of pancreatic insufficiency or with evidence of sweat chloride levels, salty baby, this can give a clinical picture of cystic fibrosis. You have to go for investigation with sweat chloride levels. You can have measure the transnasal epithelial potential difference, and you can do the genetic analysis, pick up the genes, and you can make a diagnosis of cystic fibrosis. Once you make a diagnosis of cystic fibrosis, treat the patient with clear the lungs of viscid secretions, use antibiotics against infections, and you have to in late stages, if nothing works, you can go for lung transplantation. Thank you. I hope this was useful.